All right. Hi, everyone. For those of you who don't know me, my name is Luke Wortley. I am the program director for the Upper Midwest Telehealth Resource Center. If this is your first time seeing me and not Danielle or Amna presenting on our behalf, this is actually my second stint with the UMTRC. I was a program coordinator for 3 years, including during the onset of the public health emergency. So I may have talked to many of you on the phone in the early stages of 2020 and beyond, as telehealth adoption was, increasing rapidly. So I will go ahead and just say that for those of you who may have been looking for Dr. Anwar, she has moved on to another position within our parent organization, the Indiana Rural Health Association, expanding our efforts and reach in the substance use disorder prevention, treatment, and recovery space. So we're very excited for that opportunity as well. So today we are here to talk about what I cleverly titled the two-factor problem: why the Midwest isn't using telehealth. And this really stemmed for me from, brief disclaimer as well: the views and opinions expressed in this presentation are those of the authors and do not necessarily represent the official policy or position of the Ohio Department of Health. The genesis, I think, for this presentation was that I was reading an issue brief that came out um, from a sort of confluence of agencies, and was further reinforced by CDC data as well as other regional reporting tools, that the Midwest, as defined by some agencies, and we'll get into that a little bit later. I'm happy to hash out the eternal debate of what is or is not a Midwestern state. Um, was the lowest, or had the lowest likelihood in terms of telehealth adoption and usage rate among end users over the course of the year 2021. Obviously, that was published earlier this year in 2023 just because of some data lag, but it is a very comprehensive report, and the sample size and the statistical N of the numerator is quite large. So I think it's worth looking into. So today we're going to discuss the multimodal factors that influence a patient's and provider's decision to not engage with telehealth services, including trust, digital literacy, cost, accessibility, and access, among other factors, both endogenous and exogenous. Outline the current trends in terms of data at the national and state level in terms of broadband access, telehealth usage rates, and perception statistics. And then finally, we will try to bring the conversation full circle to center it on interdisciplinary understanding of these multiple layers of identity that include racial and ethnic background, socioeconomic status, age, and geography. All of these things play a role in end users' decisions to use and engage with telehealth in the first place, as can they influence a provider's decision to integrate telehealth into their workflow. So let's begin. We're going to start with what is the two-factor problem. Going to go through some data, get some patient perspective, some provider perspective, and then rather than engaging in the classic pitfall of population and public health style presentations that leave you with all of the barriers and then say, thank you, do you have any questions? I'm going to try to at least attempt to synthesize some of the literature review I have done to talk about what do we do about it. And then all of the relevant citations and image credits will be included. And then if we have time, I would love to engage with some Q&A. So this shouldn't really be a surprise for those of us who are involved in the digital health space broadly, but I do use scare quotes on this slide. The problem, predictably, with telehealth adoption is multi-layered, but it really can be reduced in many ways into two primary constituent halves of the problem: patients or clients or end users, and providers and staff. The two-factor problem is two-pronged because these are sort of the age-old dichotomy as well as symbiotic relationship that has always been at the center of healthcare interaction. And of course, this isn't unique to telehealth. It's across the continuum of care, whether that's primary care, specialty care, insert, wraparound services, soft skills training, all of these things that that go into the work we do. So I guess I should note, many outlets, including the Center for Diseases Control and Prevention, report that as many as 16.6% of adults had a visit with a doctor or other healthcare professional in the last year, which is a little, or did not have a visit with a doctor or healthcare professional, and that's a relatively high number. And other analyses even say that between 2016 and 2022, nearly 30% of all patients who received any care didn't even see a primary care physician. Other media, I'm sure that you've seen, this has made its way into publications like Time Magazine, the New York Times. I mean, mainstream media that's not just Health Affairs or the New England Journal of Medicine, um, state that nearly 1 in 4 American adults don't even have a regular primary care provider. And obviously, all of these things contribute to an impending population and public health emergency, which has nothing to do with the rampant spread of a pandemic. So this is obviously a tension that we're experiencing, not just in the telehealth space but also in in-person care. um, so with that said, I'd like to talk about some of the data that has been cited, not only in this issue brief, but in other places as well. Um, in terms of our region, these numbers might seem a little bit misleading. In terms of households with a computer, this was based on Census Bureau estimates that aggregate data from a lot of other federal reporting resources. Over 90% of all households in the 4 states of Illinois, Indiana, Michigan, and Ohio, the UMTRC region, have access to a computer, and over 85% of households within these 4 states have a broadband internet subscription, at least nominally. Now, unfortunately, the issue with these aggregate numbers is that it's certainly not nearly as granular as some of the broadband reporting data that's available on the state level. And I think most states in the country now have a pretty comprehensive mapping tool that's interactive, where you can filter things to find broadband coverages. And of course, without being too obvious, I do still feel the need to state that these numbers are generally dependent on rurality as well as socioeconomic status. And so, those 15-ish percentage points of households without a broadband internet subscription, I think we generally tend to perhaps spuriously correlate only to rural residents who don't have access to the broadband infrastructure. Um, and I think that that's worth pointing out, because obviously that is a huge determining factor as to whether or not you're going to even pick up a device to try to access telehealth services. But it's also worth noting that there are plenty of broadband sort of dead zones in urban areas as well. Especially if you factor in socioeconomic status and any kind of pressures that may squeeze particular patients and whole groups of people um, on their monthly expenses to actually continue their subscription. So depending on when these numbers are collected, these numbers could fluctuate, a few tenths of a point here or there. But when you start factoring that in on a monthly basis, that could be thousands of people in each state. So I do also want to address that each of our 4 states have a significant number of health professional shortage areas. This map comes from the Kaiser Family Foundation, but there are a lot of other reporting agencies, including our fiscal agent, the Health Resources and Services Administration, where you can look up health professional shortage areas on a very, very granular scale at the county level, sometimes even by zip code and census tract. And not surprisingly, most health professional shortage areas, whether that be primary care or mental health, HIPSAs as we call them, generally tend to be localized and concentrated in more rural regions of our 4 states. But as you can see here, I mean, the sheer number of primary care and mental health professional shortage areas in our region is pretty staggering. Illinois and Michigan, in particular, rank among the highest in terms of need for number of providers to close that gap, to remove the health professional shortage area designation. Um, And as we can see here on the map, they are outlined in dark blue. I guess I should also note here, when we're talking about telehealth usage rates from that data brief that I was talking about, um, during the 12 months of 2021, you see that the highest adoption rate was the Northeast region, the lowest being the Midwest, then the South, and then the West being actually higher. Sorry, that's an error on my part. And I should note that the National Center for Health Statistics, coming out of the CDC, in conjunction with the Census Bureau, defines the Midwest with the states of Illinois, Indiana, Iowa, Kansas, Michigan, Minnesota, Missouri, Nebraska, North Dakota, Ohio, South Dakota, and Wisconsin. And as I said, I'm more than happy to have that long and involved discussion of geography and what is and isn't a Midwestern state and where it starts and where it stops. Especially as a original resident of Kentucky, there's always a big debate as to which geographical region it fits in. So I'm used to the discussion. At any rate, it is also worth reporting that this data brief includes phone and audio only visits. So the number of actual just synchronous visits with audiovisual capability through any kind of device might actually be lower. That this data brief did not break those numbers out specifically. It should also be noted that telehealth usage rates generally tended to increase with age, with a much lower adoption rate for patients aged 18 to 29 at only 29.4% of those patients reporting having used telehealth, and 43.3% of persons aged 65 or older reported using telehealth within that time frame. It is also broken down among gender lines. Women were more inclined to use telehealth at a rate of 42%, whereas men were only adopting telehealth use at a rate of 31.7%. And it is certainly worth noting as well that racial and ethnic lines help define some of these statistics as well. Non-Hispanic white adults were far more likely than their Hispanic and Latina counterparts, as well as their non-Hispanic Black counterparts, to use telehealth, as well as non-Hispanic Asian adults. Actually, the highest usage rates in terms of rate per population was actually among non-Hispanic American Indian and Alaskan Native adults at nearly 2 in 5 to use telemedicine services. So that is a massive disparity from 1 in 3 to 2 in 5, and sometimes even higher depending on age and other factors as well. And some of these other factors include educational attainment. Obviously, this is a tough nut to crack, especially I know here in Indiana, where we are located. There's a massive disparity, generally speaking, between our urban and rural counties in terms of educational attainment for those people who have attained a high school diploma, and then the percentage of people who have attained a bachelor's degree or higher falls off pretty precipitously the more rural the population is. So for instance, in this report, among patients with a college degree or higher, 43.2% reported using telemedicine in the previous 12 months, compared to 39% of those with some college. And then that number drops to only 30% among those with a high school diploma, and 28.7% for those who did not finish high school. So that's definitely a predictive factor. And then I also think it's worth noting that socioeconomic status definitely plays a role here, not just because of internet access, but perhaps device access, and all kinds of other mitigating factors. For instance, adults who were in households living at 400% above the federal poverty level minimum, that number stays pretty consistent. Nearly 2 in 5 reported using telemedicine in the previous 12 months. And that number drops as you get closer and closer to the federal poverty line, and then really drops off, where the national poverty rate where people are living within 100% or below even the federal poverty rate. And just for those curious, the current 2023 federal poverty level for individuals is $14,580 and $30,000 for a family of four. And you can find that on the Health and Human Services website if you so choose, or check out the references at the end of this presentation. And the national poverty rate in 2022, as reported by the U.S. Census Bureau, was around 11.5%. So, and we know that all of our, county level and municipal level statistics are going to be, some statistical deviation from those averages, with some of our counties being particularly vulnerable when it comes to socioeconomic status. And then, of course, it goes without saying, I think, that geography is a huge determining factor, more even, I would say, than a predictive factor for telehealth usage among end users. As telehealth use by adults decreased with decreasing urbanization level from 40.3% of adults living in central counties of large metropolitan areas using telemedicine within the last 12 months, down to 27.5% among adults living in non-core areas. And for those of you who are interested in all of those various definitions of rurality, I'm also happy to get into the weeds on that, as many of the federal agencies that we work with all have their own definition of what is metropolitan, micropolitan, non-metro, non-core, all of these different terms. So that's just that sort of high-level overview of the statistics that we're dealing with. It should also be noted that since I've talked about some of that, I've included some data tables here with relevant citations in the references section at the end of the presentation that deal specifically with our four states on the state level. And one of the first things that I want to point out is that the four-state region that we serve, Illinois, Indiana, Michigan, and Ohio, all have a relatively higher median age and a higher percentage of residents age 65 and higher, which should actually be predictive of higher telehealth usage rates, but they are not. I also included a couple notes here on the gender breakdown, and I have a little asterisk here just because I think it's worth noting that obviously when I use the term female persons, I'm just quoting from the Census Bureau's statistics. We obviously know that terms with gender are much more complicated and encompass a wider range of identities than just this binary. Same with my double asterisk here in the race and ethnicity column, because Hispanic and Latina is not actually necessarily by the Census Bureau categorized as a racial identity, as it is an ethnicity that can include any racial origin. So just as a heads up, that's why those asterisks are in there. But as you can see, in Ohio in particular, is pretty consistent with Indiana, where Ohio has a higher high school graduation rate, but a comparable rate of fewer than 1 in 3 people having a bachelor's degree or higher, as we saw from the previous slides, that this is a predictive factor for telehealth usage. And all four of our states here have a higher average poverty rate year over year than the national average, and the income per capita generally tends to be lower in our four states as well. So as you can take a look at this when we send out the recording. But one of the other things I would like to point out is that Ohio is also home to, or I guess over 1/5 of its population is in rural communities. So it's definitely worth looking into that as well. And I think it's worth actually pointing out where we're getting some of these other statistics from. So the telehealth service rates in 2023, this is 2023 data now, or at least published in 2023, actually says that 15% of office-based physicians used any form of telehealth services in 2018 to 19, which then increased to 87% in 2021. Obviously, we know the onset of the public health emergency was a massive factor in driving that usage rate up. But I think these next two bullet points are perhaps more illustrative of what we're going to get into in the next few slides. Smaller self-employed physicians were 17 percentage points less likely to use telehealth in practices with 3 or more practitioners. So I think that that's actually like really insightful in the sense that you can potentially pinpoint one mitigating factor and ways to overcome those challenges and barriers right away, which is be able to try to target smaller offices to help seamlessly integrate workflows. And then finally, 53% of physicians used telehealth services for less than 25% of their patient visits, while less than 20% of physicians use telehealth services for 50% or more of their patient visits. So even with the onset of the public health emergency, and even as that adoption rate just climbed so precipitously, it's still worth noting that over half of physicians that were using telehealth services in any form used telehealth services for fewer than 1 in 4 of their patient visits, while only 20% of physicians use telehealth services for 50% or more. And I think we all know, reading between the lines here, many of that 20% of physicians were probably engaging in some form of consultation for specialty care or mental and behavioral health services. So here are some of the predictive factors for offering telehealth services. And I guess I should note that before I get into some of these, coming out of the Office of the National Coordinator for Health Information Technology, physicians that are participating in certain payment models, we're talking patient-centered medical homes, accountable care organizations, or other merit-based incentive pay systems, were significantly more likely to use telemedicine services than non-participants. So I'm just going to throw that out there because that's the last bullet point on this slide. But some of the other ones here I think are a little bit harder to quantify, just because the literature reviews that I've done, despite the fact that the evidence is growing and it's becoming more robust as more people publish, the evidence base is still quite shallow overall in terms of telehealth usage, effectiveness, audits. I mean, we just don't have the breadth and depth of information that we do in the academic community, as well as some of the other federal reporting agencies, as we do for other things that we've been tracking for a lot longer. So some predictive factors for physicians or any other kind of provider offering telehealth services include the physical infrastructure, obviously limited internet connectivity in rural communities, not being able to have access to the devices needed to actually connect with patients, or even if the physician has them, then perhaps the patient doesn't, right? That's a predictive factor, as well as perhaps not necessarily having done some of the requisite work to integrate telehealth and telemedicine services directly into their workflow so as not to disrupt in-person care, especially as we resume many post-public health emergency services. Obviously, the location and size of practice and social vulnerability are huge. The location and size of practice I just got into in the last slide. It's worth noting that one study that I looked up found that providers in small practices from communities with a high social vulnerability index, which is a statistic that is used by particularly the CDC, were almost twice as likely as providers in communities with lower social vulnerability index to use just a phone or an audio only visit to engage in telehealth, rather than a synchronous audio visual modality. So that's worth noting. And next we have reimbursement rates and insurance acceptance and coverage. We'll get into that here in a little bit. Obviously, as advocates, it is frustrating to see continued thorny issues that are unclear, or that the perceived return on investment is going to be lower. So this is obviously going to be ever present. Patient demography is going to be huge, as we saw earlier. And this one is one of the ones that I want to get into. It's not just about not getting paid, but some recent studies have shown that video telehealth utilization, so a synchronous audio visual capable platform, really influences a provider's perception of its quality compared to in-person visits. Um, as well as whether or not the and this perception is also colored by the perception of user um, interface and whether or not it's accessible and easy to use. Not only for the patient on the other end, but also for the physician there in the office or the advanced practice provider, insert provider here, right? And furthermore, I mean, limited technology and health literacy on the patient end provides a significant barrier, but digital literacy on the provider end is also a massive problem. Um, and they pose major challenges for accessing telehealth, especially for patients with limited English proficiency. And some new evidence in the literature review that I conducted suggests that prior experience with a video visit might actually help overcome some of these barriers. But the current state of technology and user friendliness of some remote monitoring devices and platforms that you use to actually speak with your physician or other provider and chat and those sort of things, they vary wildly, as the vendor landscape, as we know right now, is very wide open. And so that leads to a lot of differing factors that lead to acceptance among both providers and patients, especially people who might require any kind of troubleshooting or assistance. So that those are sort of the predictive factors. So let's ask the big question, and I'll try to answer it as best I can. So what gives? What obviously these factors seem relatively self-evident. But they are sort of more exacerbated in the Midwest, not only by the data that I was able to come across and share with you on previous slides, but with some of the other things that we're going to get into here as well. In a nutshell, multiple reporting outlets indicate a pretty significant divergence in the popularity of telehealth services among patients and providers. Patients are becoming more accepting of telehealth as a sort of new normal, a completely valid way to approach healthcare, as a sort of concierge type model in a post public health emergency world, especially for non-emergent services. While many clinicians are, now that the public health emergency has essentially been rescinded, are advocating for a return to pre-COVID-19 protocols, which is a return to in-person care for most cases. And I think that this can really be explained um, by some of the data that I've already shared, but also just saying that some of these uh, some of these factors include convenience on the patient end, but also just having spent all of this time with their workflow disrupted, um, not having the requisite like soft skill infrastructure in the office to be able to meet the increased demand, and some of our constituents calling us frantically saying, "I'm not sure what to do," or even just giving up on the use of telehealth entirely. So let's talk about some of the unique factors that lead to this divergence. And I think this really does kind of come down to perceptions on both the patient end and the provider end. And some of these factors are exacerbated by our regional geography, our sociocultural lenses that we operate under here in Illinois, Indiana, Michigan, and Ohio. So some of these perceptions include a fact that a recent study from JAMA, or the Journal of the American Medical Association, published in 2021, indicated that 53% of patients surveyed in this study that they preferred an in-person visit for non-emergency care versus a synchronous audio visit. But it's worth noting that that number tended to fluctuate pretty significantly by sometimes as many as 10 percentage points based on the idea that sometimes out-of-pocket expenses could actually decrease when using a telehealth option. So while I think many people would say that they generally tend to trust in-person care over digital care, um, they are, I think, sometimes more influenced by other material circumstances than a sort of nebulous perception that they may or may not have, depending on their own lived experience. It's worth noting that many studies indicate that patients generally are satisfied with telehealth services when they engage with them, though. Some studies put this number as high as 91% of respondents indicate that they are willing to use telehealth again. This was a recent study that came out at the end of 2022. And other studies indicate that the number is as high as 95% of patients surveyed were satisfied with their experience with video visits. Now, I cite this in particular because it could be explained that here in the Midwest, in our 4 states and some of the other states listed previously in the presentation, that we have a little bit of a disadvantage in terms of consistent access to adequate devices, as well as accessing the broadband infrastructure that's already there. And so perhaps, since audio only visits are included in the initial issue brief that I was talking about, that could account for an overwhelming percentage of people not being satisfied with their telehealth appointment and deciding that, well, it's just not worth it for me. I don't like it, because maybe they had poor service, poor connection, maybe there was a tech issue, who knows, right? So I think it's worth noting that the Midwest could be at a significant disadvantage in this regard. And finally, it's worth noting that satisfaction and skepticism do vary widely based on exposure to telehealth broadly. I cited earlier that basically, if you have experience with telehealth, you generally tend to be more favorable in your perception toward it in the future, especially for non-emergency services. But this varies wildly based on age, race, geography, socioeconomic factors, digital and health literacy broadly, as I've been making the case for over and over again throughout this presentation. Then there are obviously major barriers that patients and prospective patients have to deal with, that may cause them to, again, decide that either telehealth is not for them, or it's just not accessible, or that it's just not worth the trouble, right? So some of these include lack of high-speed internet access, especially prominent in rural communities. But as we know, there are plenty of swaths of urban geographies that lack consistent access to high-speed internet access or secure internet access, even though they may ostensibly have coverage. There's also potentially a lack of access to video sharing devices. This becomes a major problem when... Okay, so Matt has asked a question here. I think, let's see, can you provide any context for what the goal is for telehealth utilization? I would assume the goal is not 100% of healthcare is being delivered by telehealth. So at what level of utilization would we decide we are doing well with offering telehealth where it's medically appropriate to patients who want to or need it to receive their care? This is an excellent question, Matt, and I have been wrestling with this personally for some time since I have come on as the director of the UMTRC, because as a staunch advocate of telehealth adoption, to alleviate some of these barriers in terms of access to care, I also don't view it as a panacea that is going to completely replace in-person care. And I, as a non-practitioner and non-clinician, would never want to tell folks how to do their job and what they would deem medically appropriate. So I'm walking a fine line here, although I would say that given the preponderance of household computers, smartphones, and the broadband infrastructure being relatively widespread, I don't know that I have a specific number that I would like to see us get to, but I would say higher than 1 in 3 for non-emergency situations doesn't seem far-fetched, especially for a provider office or system that has capacity to potentially um, make their appointments more convenient for a lot of their patients who might otherwise have major barriers to get into the office. So I know that that's sort of a non-answer, but maybe we can circle back to that at the end. Um, and yeah, I like I said, it's hard to quantify, but I would say higher than 1 in 3 for these non-emergent situations is definitely a goal. Um, so the next one, and I've talked about this in the previous slides, there are some providers, and we encounter this here with our parent organization, offering many services for um, especially mental and behavioral health, as well as you know preventive care and community paramedicine and a lot of other things across the continuum of care. There are some providers who just are straight up reluctant, and that is obviously going to have a direct impact on you as a patient being able to see them. So that's a big deal. Language barriers and accessibility concerns are sort of two sides of the same coin. We talked about how telehealth perceptions among people with limited English proficiency could be impacted dramatically, just because it could be a very frustrating experience without a protocol or tool in place to address those concerns. If the patient speaks a language other than some of the more common ones used on language lines and other vendor solutions. So that's definitely something to talk about. I also did a presentation earlier this year for this group about health equity and access to care when it comes to telehealth, and accessibility for people with disabilities across that spectrum is huge, right? Not having a platform that integrates with closed captioning software, not having multiple ways of presenting information, things that are considered best practices but can slow down the workflow if not implemented effectively, can also be a big concern on the provider side as well, which we'll get to in a minute. Obviously, I keep hammering this home, but socioeconomic status includes not just how much you make, but also the your educational attainment, whether or not you have healthcare coverage in terms of insurance, any other kind of like direct benefit from an employer, or being unemployed or potentially unhoused, are also huge. And then finally, just the other sort of branch here is that while some providers might be reluctant, there are some patients who might be as well, just because they distrust um, the whole apparatus of using a digital device to talk to a doctor. And there could be even a broader sort of more underlying sense of distrust in the healthcare system generally. And so then having an additional mediating factor in the form of a laptop or a phone might enhance that even further. So next, let's talk about some perceptions from the provider side. I have a couple other studies um, cited here. Essentially, clinicians who worked for telehealth firms and startups have often cited multiple factors that lead to too short appointment times, overworking in large patient volume, lower quality of care generally, and fuzzy rules on the rigor of more complex cases and managing certain medication. And obviously, this is uh, paramount. And I want to reiterate what I said to Matt earlier. I'm not a clinician, and I'm not going to pretend that I have insight, um, into every single case as to what should and shouldn't be handled via telehealth. I don't actually think that we have arrived at the optimal use case for telehealth in every single situation yet. So, that's hard enough. But then you add on top of that especially during the pandemic, and I'll get to a personal story that's centered here in Indiana here in a minute. Um, the rate of physician and clinician burnout generally is climbing higher and higher and higher. And I think obviously a lot of that is influenced by the public health emergency. Um, but adding additional patient load to an already stressed system just because you have the access to it doesn't necessarily mean that you're going to get the desired result. Furthermore, many clinicians also claim that telehealth appointments did not enhance pre-existing relationships with patients, much less offer an opportunity to build a new one. And obviously, this is down to personal disposition, cultural context, a lot of other factors that are hard to quantify. But I don't think that any of us would deny that building a relationship with your provider over the course of ideally many years is not a good foundation for good healthcare. So, obviously this is going to be a challenge to overcome. There's also a lack of a strong and deep evidence base for clinical intervention. I alluded to this earlier, but there are plenty of people out there who are interested in telemedicine applications broadly, but are having trouble finding the literature to cite. And so, until those longitudinal studies, those big, massive scale, data collection initiatives start bearing fruit here in the next couple years, this is going to be a persistent problem. Finally, many surveys indicate that something as high as 60% of clinicians found it significantly more difficult to examine patients thoroughly. And I know, speaking from personal experience here at the Indiana Rural Health Association, and having a parent who is from a rural town in northern Ohio, that sort of relationship building, as I alluded to, but also just the ability to kind of like sit there and chat with somebody in person and pick up on little cues, is sometimes invaluable. The flip side of the coin, though, of course, is when you're potentially seeing patients remotely, you might gain insight into some of their home life that you wouldn't have otherwise as well. So we're going to get into that here in a little bit. And then finally, other providers still see the pitfall of telehealth access becoming another driver of overutilization of an already stressed system. Now, and this type of reporting is certainly open to interpretation, I think, even though the numbers kind of speak for themselves. It just kind of depends on where you come down on those particular issues, but it's not unreasonable to say that there could be an argument to be made that the convenience of telehealth and the overdependence of our system broadly on providing a consumer experience for telehealth has some people a little bit nervous that we're going to be just flooded with non-emergent requests for telehealth appointments that are taking up an inordinate amount of time and potentially leading to overprescription of basic things like antibiotics, which we know from in hospital systems, antibiotic stewardship and hospital-related infections are on the rise. So there's a lot of other things here, and these are very valid concerns. And then finally, before I get into some of the nitty-gritty here, it's worth noting that obviously there are barriers for providers as well, even though, I think many end users and patients want to see them as not only the clinician, but also their tech support and their technical assistance provider and everything, because it's all right there. And so, they're human as well. So any kind of distraction during a virtual visit is going to make it harder to examine somebody. Even at a remove already makes it difficult. A very chaotic vendor landscape makes it very hard for providers at all levels, small practices, large systems, to effectively evaluate solutions, I think. Reimbursement and regulatory concerns is the consistent refrain we hear over and over again. That it's just not worth the ROI is just not worth it. The return on investment for providing the care in terms of dollars gained to just keep the practice afloat, especially in smaller communities in non-metropolitan areas who don't have as much volume. It's tough. Difficulty using the platforms. I've talked about this. And declining perception and the effectiveness of telehealth. And then, as I had talked about earlier, clinician burnout generally. So to talk to that clinician burnout story, I want to talk about a small healthcare system here called Windrose Health, which is a federally qualified health center in Greenwood, Indiana, which is a southern suburb of Indianapolis. Not too dissimilar, I think, from some of the Dayton, Ohio suburbs, or maybe even some of the outer edge Columbus suburbs. Certainly not anything like a Beaver Creek or like a Dublin or something, but somewhere in between, right? Very much a strong working class background, but the population has sort of exploded over the last 50 years. But this is just, I think this is a good representative sample of, I think, some of the things that you might hear anecdotally if you talk to people throughout our region. Basically, Healthcare IT News asked the CEO if their clinicians enjoyed using telehealth, and essentially the TLDR is a few did and most did not, and many of them, the CEO indicates that they disliked using telehealth so much that they were willing to come in person with personal protective equipment and work 10-12 hour shifts for days on end, just because they did not like being in front of a screen that much. And I don't think that this is a super unique story. So what do we do about it? What's the goal here, and how can we, especially as Midwesterners here, really have an impact on the patient and the provider end? The first thing, obviously, is to make the case, and obviously there are realities here that we have to acknowledge. Number one is that you have to make the business case. And this is the hard part because of those reimbursement and regulatory concerns. But we have to emphasize the idea of indirect cost savings in terms of transportation, time lost, getting childcare, taking kids out of school, parents taking time off of work, all of these things, right? I know Illinois in particular has a parity law on the books. Ohio, Indiana, and Michigan have all kind of flirted with telehealth parity in terms of private payer reimbursement. And so, that's something that hopefully comes down and gets codified, and that can help you make the business case. And I think the other thing is that we have to, especially on our end as federally funded technical assistance centers, we have to do a good job of advocating for efficient use, optimal use, and integration with existing workflows to try to not disrupt the pre-existing job that people are already doing. And of course, then there's the human case, right? I don't think anybody gets into medicine on a core level, right? And along the continuum of care, or even community-based organizations that might utilize telemedicine just to make money. So I think we have to emphasize the increased access to care, because we know that decreased access to care is directly correlated with higher morbidity and mortality, regardless of socioeconomic circumstance, regardless of race and ethnicity, almost across the board. We have to emphasize that some modalities have benefited tremendously, including mental and behavioral health services. So it expands the continuum of care dramatically. And then finally, when telehealth and telemedicine are well implemented, they can alleviate some of these sort of chronic disparities that seem like structural barriers that we can never overcome, especially when we are thinking about people with limited English proficiency, if we are thinking about folks with disabilities, etc. The next thing that we can do are joining peer groups. I think one of the best things that we can do as the Telehealth Resource Center for our region is try to provide a convening space for people who are advocates of telehealth and telemedicine, but may be experiencing pushback, or may be wanting to try to figure out how to better optimize. And that's something that I'm hoping to do in my new tenure as the director here. Next, as things get published, we have to continue to consult the literature. As more and more data becomes available, the better informed our decisions can be, right? Next, evaluation. And this is perhaps one of the most concrete things that I think we can do as advocates from the patient and provider end. We have to be able to come up with a standard procedure that works best for your facility and your context, that evaluates hardware and software effectively, that actually is able to find things that are going to help you run a telehealth program smoothly. Patient satisfaction is also another metric that I think has been underutilized, and I think that there are a lot of better standardized tools out there now than there were even 4 years ago. But there's no reason why you can't modify and pinpoint things that are unique to the population that you serve, because obviously, Illinois, Michigan, Indiana, Ohio are all different in their own right, and they're certainly going to be different. Being in Shaker Heights, Ohio, than they're going to be in Fairbanks, California. Your population base that you serve, your constituents that help you do your work, are going to be concerned about different things. So evaluating that and understanding it, and the market broadly and the demand is huge. Finally, we can expand infrastructure. I pointed this out in a presentation earlier this year. Ohio-specific entities, including all hospital systems, received $0 from the Office for the Advancement of Telehealth in the year 2022. And so I think it's important to form consortia, write for grants, utilize your existing connections, have the full information when it comes to regulatory concerns and reimbursement, and that's why we're here at the UMTRC. One of the things that we're going to be doing here at the end of this month is our 4th quarterly stakeholder call that gives us the state of the region. We will have updated reimbursement and billing guides, monitoring policy at the federal and state level. You can have access to that for free, and I will make sure that Danielle includes that in some capacity in the coming days. And then finally, if you are in a capacity to do so, advocate for your own legislative change at your state level. And then finally, I think we have to be really honest for those of us who are even just remotely interested in engaging in digital health broadly. I think we have to address provider and patient concerns directly. I think we have to understand that skepticism and negative perception is not going anywhere. That just because there was this, meteoric rise in telehealth usage rates, that we're all of a sudden in the clear and everybody just accepts it as a new part of life. I don't think that that's true. So I think large scale education and training. And again, this is something that we have to work with you on too, because we have to make sure that it's worth your time. So that's something that we have to address, and we have to continue to emphasize best practices when it comes to health equity, quality improvement, with the end goal of justice across the continuum of care. So I've also included some Ohio-specific resources for you. All of these links are incredibly useful and helped inform some of my statewide perception data here. You obviously have the broadband mapping tool from the government's office. The Great Lakes ADA Center is huge if you have accessibility concerns, not just for technical assistance, but also for legality. I have a lot of other links here, including the Ohio Commission on Minority Health and the Latino Affairs Commission, along with other advocacy agencies that specifically target underserved populations. The Ohio Hospital Association publishes a lot of great resources in terms of what telehealth codes generally are covered by which payers, in addition to the information that we provide. And then, of course, our website down there at the bottom. We are running up against time, so I want to make sure that I leave a few minutes for Q&A. These are all the different ways that you can contact us. Please subscribe to our podcast on your podcatchers, A Virtual View with Danielle. She's an excellent interviewer and actually just had a guest from Ohio who is a doctoral candidate at Case Western Reserve. And so check that out. That's with Albert Ferreira. We have a YouTube channel, Facebook, LinkedIn, all of the above. And then, of course, here are my image credits and references. So I will stop sharing my screen for now. We can reconvene, and please feel free to use the chat function or the Q&A function if you have any burning questions. Oh, you're welcome to hear that. I tried to provide some value here, so I'm glad you got something out of it. Okay, Sean asked, does the UMTRC do any advocating with payers for things like covering devices like TytoCare? The short answer is no, but I'll give you a little bit of context. Because we are a federally funded entity, our advocacy has very strict limits, right? So we can't, for instance, even offer an elected or appointed official a an official space to talk even just about the facts of issues on any kind of committee or on the floor of a legislative body. Furthermore, we also do not directly engage with recommendations or anything for specific vendors, just because we want to maintain our vendor neutrality. We can help you do evaluation and that sort of thing, and we can obviously say, here's what the literature says are some, policy recommendations for advancing telehealth parity, streamlining reimbursement, all that kind of thing. But no, we don't do anything specific to that level. But if you are interested in advocacy generally, Sean, you might want to try to get a hold of me or Danielle after this, and we can kind of set up a 30-minute intro call and just talk through some of your other questions.
And I will say real fast, we will be sending out these slides later this week. So if there are any of those links that you're curious about, you will have the opportunity to take a look at these slides, take a look at those resources. We will also be putting up a recording of this presentation. So for the folks who didn't have the opportunity to join us today. But thanks so much for hopping on, guys.
I also just put my email as well as the sort of the email equivalent of a 1-800 number in the chat if anybody is interested in reaching out to us to follow up.
Oh, and we do ask that you fill out that evaluation link that Jessica has posted in the chat. We like to know what we're doing well and what we can improve on. So that would be fantastic if you could go and fill out that evaluation.
Any other Q's and hopefully A's? Okay, well, we are right at 1 o'clock, and I will go ahead and say that we can conclude, and you're welcome to sign off. But if you have any other questions or want additional clarification or context, feel free to stick around. I will be here for another few minutes as well. Thanks again, everyone.
Thanks so much, guys.